Hi, my name is Amy Myers. I'm one of the internal medicine clinical pharmacists at Vanderbilt Hospital, and I appreciate you taking the time today to listen to me talk about deprescribing benzodiazepines in older adults. This is a topic that I'm personally very passionate about, and I feel like we can have a lot of success and a lot of impact with our patients. So most clinicians are aware of some of the risk of benzodiazepines. We know that older adults have increased sensitivity to benzodiazepines, decreased metabolism of the long-acting agents, and the Beers criteria nicely outlines the association of these medications with an increased risk of cognitive impairment, delirium, falls, fractures, and motor vehicle crashes. This is a list that would scare any older adult or any clinician caring for a geriatric patient, but we're often very hesitant to discuss stopping these medications with our patients because of the true psychological and physical dependence that these medications can create in our patients. So I was really encouraged by the literature showing that when they looked back at a variety of minimal interventions, such as a tailored letter from a primary care provider to the patient, even small interventions can make a difference. In this meta-analysis, they found that in studies where a tailored letter was sent from the primary care doctor to patients, the number needed to treat for one discontinuation is only 12. I found other information helpful in a 2015 Cochrane review where they looked at cognitive behavioral therapy use to assist in benzo discontinuation. They found that a variety of cognitive behavioral therapies were helpful, and they really had a very wide definition. This could be as simple as distributing a pamphlet or a booklet to a patient by mail, and we'll talk about that specific intervention later, to something more intensive like group therapy or support groups. When they looked at the studies that had the greatest success for sustained discontinuation, those were studies in which the patient was given a specific tapering plan. So we know that to set our patients up for success and have sustained discontinuation, we want to include that taper. I practice in the acute care setting, and unfortunately, there are no interventions, no studied interventions or published interventions looking at benzo cessation interventions to empower patients to make the decision themselves in the acute care setting. So personally, I will mimic an intervention used in the community setting called the Empower intervention. And this paper was published by a group of researchers that have also done the deprescribingorg website and lots of other wonderful materials. So the thing I love about this intervention is the simplicity. They use direct-to-consumer marketing to try and empower patients to decide to discontinue benzodiazepines on their own. So they sent an 8-page letter-sized booklet, 14-point font, 6th grade reading level, and the pamphlet used cognitive behavioral therapy and constructivist learning theories to try and create dissonance between the patient's perceived view of the benzodiazepine and what the actual facts are. When they looked at the rate of benzo cessation at 6 months, they found a number needed to treat of only 4.35 to either have complete cessation or a 50% dose reduction. So I think it's really wonderful, really encouraging to me that just mailing this packet was successful for these patients. So I wanted to take a few minutes and walk you through the packet and give you a hyperlink to access the packet yourself if you ever want to share it with your patients. So in the acute care setting, I'll typically print this off and visit the patient's room and say something like, "Mrs. Smith, my name is Amy. I'm one of the pharmacists, and I came by to talk to you about one of your medications. Your doctor and I are concerned about this medication. The medication is your Ativan." And at this point, I really don't want to engage the patient in any kind of a confrontational conversation. I'm not going to have time to build a lot of rapport with the patient in this interaction, but I certainly don't want to start off on the wrong foot. I give them the pamphlet and I ask them to take some time and read through it, see what they think, and that I will be back for us to talk further about next steps that are best for them. So really nice. You can see the first page here. It's very alarming. You may be at risk. And it starts out with a quiz that aims to employ cognitive dissonance theory. So with cognitive dissonance theory, they try and create two conflicting cognitive thoughts, and this discomfort will pressure you to either choose one or the other. So there are currently held beliefs that they need this medication, and then we're going to provide them with facts related to the medication to try to create that dissonance, and the uncomfortableness of that pressure will force them to either choose one or the other. That's cognitive dissonance theory. So you can see true or false questions. The dose that I'm taking causes no side effects. This medication is the best available option to treat my symptoms. The next page has this picture of a friendly geriatric patient. I think the investigators' aims were to say, look, this person looks like you can be this person. So the answers go through the questions that are posed on the first page, and again provide some facts about the benzodiazepine. They encourage the patient to ask themselves, yes or no, have we been using this medication for a while? And they educate the patient that use over about 4 weeks, especially for the indication of insomnia, is really not indicated or effective. The next paragraph talks about aging and how your body handles medications differently as you age. And I think their hope at this point is that the patient thinks, okay, perhaps there's a problem with my medication, but I really need it. The next 2 pages explore some alternatives, talking about behavioral changes and lifestyle changes to increase sleep or stress. And then one of the last pages, again, I think they want to give someone that a patient would relate to. Mrs. Robinson shares her story. She's been taking lorazepam, a sedative hypnotic drug, just like yours. So Mrs. Robinson talks about the concerns she had. She talks about the tapering she did, some of the symptoms she had, some of the withdrawal symptoms, and how she managed those. And the final 2 pages go through a tapering schedule that just looks at halving and then quartering pills so that it can be applied to different dosage strengths and different medications. And they conclude by asking you to seek a conversation with your healthcare provider, because we really don't want patients self-discontinuing these medications because of the dangers associated with withdrawal, and because we can help them succeed if they begin to experience withdrawal symptoms or are tempted to relapse. So in my personal practice, I like to have a follow-up conversation, and if you were to hand this pamphlet to a patient, I would suggest that as well. And this is a good time to assess their readiness to change. So to give an example, if a patient is in the pre-contemplative stage, at that point, we want to identify barriers and misconceptions and address their concerns. We definitely want to validate their feelings. You might say, I hear that you're concerned about relapse. Many patients successfully stop these medications. We will follow up every 2 weeks to help support you. And then ask the patient what supports they might have, what people might be helpful to walk you through this process, or as they voice different concerns, address those specifically. This can be a very short conversation. You certainly want to document the outcome for the next provider. And one thing to be encouraged by is success is just moving along that continuum of readiness to the next step of readiness to change. Certainly we want to document the outcome and share that documentation with their outpatient provider. And specifically, I always try to make sure we communicate with whoever writes that medication when you look them up in the Tennessee Controlled Substance Database. I mentioned deprescribing.org, and I wanted to highlight a really nice algorithm that they have on their website. So they talk about looking at the indication for the benzo, engaging the patient, recommending deprescribing. And one thing I wanted to point out, you can see the red arrow, is that they talk to the patient about potential withdrawal symptoms. So when patients are aware of the adverse outcomes that might happen, I think that actually empowers them to feel more comfortable with the process. We're more comfortable with the knowns than the unknown. I also wanted to highlight that they recommend monitoring every 1 to 2 weeks for the entire duration of the taper. We want to look at their withdrawal symptoms. Are they having anxiety, diarrhea, insomnia, and talk to those patients about lifestyle and behavioral therapy that can help with that. And finally, on the back of this algorithm, they just list each medication, the dosage strengths. For some of the really long-acting agents, toward the end of your taper, you may decide to do a drug-free day because it's not appropriate to half the tablet, or you may switch to a short-acting agent like lorazepam toward the end of the taper to finish it out. A couple of resources that I love are the customizable benzo handout that I showed earlier. The original Empower packet just has some nice information about stopping benzos. And then deprescribing.org has the algorithm that I mentioned, patient handouts, and some deprescribing information for other potentially inappropriate medications.